All right. So welcome everybody. I'm so happy that you're here today. Basically, this came about because we got to talking about, fielding helpline calls, certainly in regard to crisis, which I know that we don't get a ton of crisis type calls, and that's really not the focus of this particular presentation, but just in regard to really what's expected in when you're answering a call to your affiliate from someone who's looking for help. So, we recruited Sam from NAMI-NYC City Metro, and of course, our own Christine from NAMI New York State, who obviously are the resident experts on helpline calls. They're going to do a presentation, and then following that, there'll be an opportunity for anyone to ask questions or make comments or share any other kind of information. And again, I am recording this, so this is something that if you have a new volunteer or staff member that comes in and is going to be answering calls, you'll be able to share this information with them as well. So I think at this point, I'm turning it over to Sam, and he's going to.
Thanks so much, Wendy. Really great to be here. Thanks to you all for coming. Looking forward to getting to talk a little bit. So just a little bit more about me quickly. So my name's Sam. I am the helpline manager at NAMI-NYC. We have a good size helpline. We get about 1,000 calls a month. We have 15 helpline responders. And so a lot of the training that I'm going to be doing with Christine today is based off of some of the trainings that we've developed at NAMI-NYC and that we give to all incoming helpline responders who start out. I came to NAMI with, I think like a lot of people, with lived experience. So I've called helplines myself. I feel fortunate to now be in a really good place to be able to staff one and be able to do some trainings. So without any more, I'll get us started. So I'm going to share my screen and bring us in. Christine, I don't know if you wanted to do any introduction for yourself now, or if you wanted to wait for you.
Sure, I'll do it now, then I don't have to break it up in between. But as many of you know, I'm Christine Rickerman. I'm the NAMI New York State Information and Helpline Resource Coordinator. And, again, I think I'm familiar with many of you, as a lot of the calls I get, I do refer to the affiliates throughout the state, and which in a sense, by any means, I don't get the volume of calls that Sam does, but I get them for the whole state and then disperse them as necessary. But again, we can start with the presentation. So Sam, I'll turn it back over to you.
Thanks. All right, so as a bit of an outline for what we're going to talk about today, so we're going to talk about things kind of broken up into these 4 pieces. We'll start with what does a NAMI helpline do? We'll move on to the 3 pillars of helpline responding and a toolkit for them. So this is really what are the things that happen on a helpline call. Then we'll talk about the timeline of kind of what are the different stages of a helpline call. And then we'll talk about what's called scope of practice, which is what are the things that kind of fall within the responsibilities of a helpline responder, and what are things that maybe are outside the responsibility, things that maybe someone's individual therapist should be doing, or something. What are things that other hotlines are supposed to be doing, and when do things kind of fall outside of our kind of radius of what we should be doing. So to start with, what does a NAMI helpline do? So NAMI helplines provide are a peer support service, which provide emotional support, psychoeducation, and referrals to people living with mental health conditions, family members and caregivers, mental health professionals, and the public. Ultimately, most often we offer people a next step when they're stuck. People will kind of come across something, something will happen, and for a lot of people, they just need help either navigating the mental health system, which is really often something that we'll do, or even just someone to talk to because they feel that they're stuck emotionally in some other way. So on the left, I have, there's this diagram of kind of different kinds of call-in services. So at the top, the the hottest, the warmest is hotline, and at the bottom is an info line. So you'll see that NAMI helpline is kind of somewhere in between. So an info line is really something where you can call in and just learn a little bit of information. I think right now there's the New York State COVID hotline. That's not their emotional support COVID line. They have one that's just, how long do you have to wait after COVID, things like that. That's a pretty basic info line. Then there's also things like warm lines, which usually tend to be a little bit more focused on just emotional support and really not designed to help people kind of right after crisis or right before crisis or during crisis. And then at the top, there's hotlines, which are really designed to help people with crisis and usually anything up to that. NAMI helplines are kind of somewhere in between a hotline and a warm line. So one of the ways I put it is I think often a NAMI helpline would not take a call or might not be designed to take a call from someone saying, my son is experiencing a crisis right now. He's talking about hurting himself and I don't know what to do. That would probably be a better call for a hotline, but maybe we would get the call that says, last week my son was talking about hurting himself. He was hospitalized. I don't know. And I don't know what to do because now he's been in the hospital for a week and I'm trying to start to figure out what are the things that I need to do to set him up once he's discharged to be safe and comfortable and successful. We also might take a call that's a little bit before that. So really not designed particularly for crises, but can often really help people just before, just after, or anything up to the level of kind of that. So even these calls that would be more warm line calls where it's really just an emotional support call, or info calls with people asking about our services and things like that. So NAMI helplines all run off of, and NAMI as an organization really runs off of the idea of peer support. So to talk about what is peer support, there's this video that I love from the television show The West Wing. I went to graduate school for social work and still somehow a television show is the best illustration of peer support I've ever seen. So I'll play this in a second, but in this scene, this character on the left, kind of earlier in the episode, he had a PTSD episode where he punched through, I believe, a window or something. And his character on the right is someone who's a recovering alcoholic who, in response to hearing about that incident, really encouraged him to find treatment and see a therapist. So I'll share this.
How'd it go?
Did you wait around for me?
How'd it go?
He thinks I may have an eating disorder.
Josh.
And fear of rectangles. That's not weird, is it? I didn't cut my hand on a glass. I broke a window in my apartment.
This guy's walking down the street when he falls in the hole. The walls are so steep he can't get out. A doctor passes by and the guy shouts up, "Hey, can you help me out?" The doctor writes a prescription, throws it down in the hole and moves on. Then a priest comes along and the guy shouts up, "Father, I'm down in this hole, can you help me out?" The priest writes out a prayer, throws it down in the hole and moves on. Then a friend walks by. "Hey, Joe, it's me, can you help me out?" And the friend jumps in the hole. Our guy says, "Are you stupid? Now we're both down here." The friend says, "Yeah, but I've been down here before and I know the way out." Long as I got a job, you got a job, you understand?
It's time to help people cut.
So I think that clip is just a really great illustration of what peer support is about. I think it's really about being able to be down there in the hole with someone and say, "I've been here." And later we'll talk a little bit about how exactly we can do that safely, and that when we talk about our scope of practice, when are the times when it's okay to divulge personal information or not. But really, even beyond just divulging personal information of what you've been through and sharing that as a helpline responder, the entire model is just based off of this idea that peers are there, peers can understand, peers can be there and support in ways that I think others can't always. So now let's talk a little bit about some of the goals and ethics of being a helpline responder. So some goals are, and these are broad kind of values-based goals. Some goals are that we want to respond to each and every call with warmth, empathy, and kindness. Some of these may seem obvious, but it's just good to restate anyway. We want to create a safe, respectful space in which we listen, support, and educate. We want to prioritize caller needs whenever possible for client-centered service. So sometimes I'll be on a call and someone will be saying that what they're looking for is this service. And I really know that I think something else would be better, or maybe, you know, they assess their situation with their son as one thing, and I really think that it might be something else. So even though I might have a different idea of what this client should be doing, it's still important for me to prioritize their needs, because ultimately it's up to them what they want to do. And if they're not ready yet for the thing that I think they should do, or if for some reason they don't want to do it, I really want to prioritize what they're asking for, because they have a lot more knowledge of the situation. If I'm saying, oh, I think your son needs to be in a partial hospitalization program, and I really advocate for that, I might not even know that their son has already been in a partial hospitalization program, and that it was a terrible experience. And maybe, you know, the caller doesn't want to share that with me right at this moment. So it's really important for us to be really graceful and really prioritizing the needs and ideas and wants of the caller. We also want to remain open-minded, inclusive, and non-judgmental. So all the time we will have callers who call about things that are hard to hear. And often it's really important for us to remember to come in with a really neutral, non-judgmental stance, so that if they're sharing something that might be really difficult for them to share, if they're sharing something that they're embarrassed about, or something that even we might think, you know, is something that's worthy of being judged, it's important to show them the empathy, show them the kindness and the care. We want to take care of ourselves. We can't pour from an empty cup. I think it's going to be up to each individual help client how they want to structure some of the self-care and boundaries. But we'll also talk a little bit about that at the end, some of our ideas that we have. And in terms of ethics, so we're a peer-led helpline. We do not provide professional or clinical care. So helplines do not provide therapy. They don't provide direct counseling. And sometimes it can seem a little blurry, the line between really just offering someone deep emotional support and therapy, but kind of there's definitely extremes of things like, you know, when people are talking to us, we don't need to ask such deep penetrating questions that we're starting to get to, you know, why they do the things they do and who they really are. Those really like identity-based and driving questions are really not the purpose of the helpline usually. Usually the helpline is more, is really important, but it's a little bit above that kind of deep layer. Another piece of the ethics, we do not instruct callers. We offer options and empower callers to do what works best instead. So we don't tell callers what to do. Sometimes I think of us as we really know the menu of different mental health services really well. We'll explain the menu really well, but ultimately it's up to them to decide what to order. We never share personal contact information with the caller for ethical or safety reasons. So we don't share personal cell phone numbers, personal email addresses. Different helplines can decide whether they're comfortable sharing last names for some people who are on staff and things like that. But that's really also kind of a protective factor, trying to make sure that boundaries don't get too blurred. We do not maintain any forms of ongoing support relationships with callers either. So sometimes we'll get callers who say, you know, this was such a helpful call, can I speak to you next week? And usually we try not to create that dynamic. We usually try to say, you know, oh, well, there's a lot of different people on the helpline, or, you know, it sounds like maybe what you're looking for is more of a therapy, because ultimately if people kind of want to develop that ongoing support relationship with you as a helpline responder, ultimately that means that they're developing a relationship with you that maybe would be more appropriate with someone else. Maybe what they're really looking for is a friend who has lived experience with mental illness, and what they should be doing is coming to a support group or some sort of other NAMI program. Maybe what they're really looking for is a therapist, and if they keep calling you every week, maybe it doesn't let them eventually find the right therapist for them. In terms of types of helpline calls we get, So here's 5 different types, but often they'll blur together. So one is people who just want to be heard and need some peer support. So these are really people who are just looking for someone to listen. We also get requests for mental health services, which tend to be a bit more specific. Sometimes people really know what they're looking for, they just don't know the number or if that service exists in the area that they're calling for. Sometimes people just don't know and they're just asking for mental health services broadly, and it's up to you to figure out what would be the best fit. We also get inquiries about housing, employment, or legal aid. Of course, these are things that often are related to mental health. We also get questions about NAMI services, specifically different programs that this NAMI affiliate might offer. And then there's everything else. There's always going to be helpline calls that come in that are really unexpected, that are about things that that aren't necessarily things that we train for or designed for, but we might be able to help anyway. So now we're going to talk a little bit more about what I called before the 3 pillars of helpline responding. So these are really the 3 main things that you are going to be doing on helpline calls. And I know for many of you, things that you already do. So all helpline calls generally start out with something like, thank you for calling the NAMI-NYC helpline, the NAMI New York State helpline, the NAMI Buffalo helpline, anything like that. This is, and then you say your name, how can I help you? And I like to have a phrase like this that really orients people. Sometimes people will call and they're not sure. They don't remember exactly, they're calling so many places, they don't know exactly who they're calling, or they're calling so many places, and it's just nice to get something that's a little bit friendlier. Something like, how can I help? And that's not short and abrupt. So the 3 pillars of helpline responding are emotional support, which is that we listen and validate and tend to our caller's emotional experience. Psychoeducation, so we offer information, tips, and strategies for learning about and coping with mental illness. And we offer referrals and resources. So we provide appropriate referrals and resources for callers on the next steps of their journeys. And within each of these pillars, there are different tools that you'll be using, that you can use, that I'm sure you already do use when you're responding to a call. So I even have this slide printed out, and I have it in front of me when I take calls, because really almost any time that I'm on a call, I'm doing one of these things, one of these bullet points listed. And sometimes it's even just helpful for me while I'm on a call to think, oh, you know what? I've been doing a lot of active listening and validation, but I think I might be ready to start asking them a little bit more about, let's say, their social supports. And so it's just easy for me to have this as a reminder of all the different things, all the different kind of tools I can pull out and use when I need them. So what we're going to do now is we're going to talk a little bit about each of these individual tools. So we'll start with these tools within the pillar of emotional support. So the first tool is active listening. So hearing is the act of perceiving in your ear. Hearing just happens, it's very passive. But listening is the act of hearing a sound and understanding what you hear by concentrating, processing on it. And it's actually something that really needs to be done, it's active. And so often some of these things that you can do to really actively listen are really make sure that you're listening, taking in their information, and that you're doing it in a neutral and non-judgmental way. So you're not kind of one step ahead of them, thinking through what they might say next. You're really listening to them as it comes. Other things is other skills within active listening is that active listening is patient. So periods of silence don't necessarily need to be filled. Something I once heard from a therapist was that periods of silence are actually where all the work gets done. That before that, people are really kind of running on autopilot in some way. And when there's a period of silence, it often means that people need to really think more deeply about something for the first time. But of course, you don't need to let the period of silence get too long or be awkward or anything like that. Another skill within active listening is providing verbal and nonverbal feedback to show that you're listening. So in person, this is things like smiling, eye contact, leaning in, if someone's talking to you, not looking away, things like that. But over the phone, often this means just these small little verbal cues to let them know that you're still listening. So just saying, oh, I see, or just saying like, just sometimes it can be awkward, especially if people are calling into the helpline. They can feel awkward when they just don't hear anything on the other side of the line. They can think, is anyone still there? But if you really consciously try to provide some verbal feedback, it can be really encouraging, really active listening. And then another skill is just asking questions, which I think will transition us to one of the next slides, but asking questions, following up on things that people say to really get a better understanding of what they're going through. The next kind of tool we're going to be looking at in emotional support is called empathetic response. And this is essentially after you've listened, responding with empathy. So there's kind of three ways to do this. Number one is reflecting. So hearing what someone says and just reflecting it back to them, just saying it kind of quickly in that, saying they said that they're so frustrated about how they've been calling the local hospital and haven't heard back, and just saying, oh, I'm so sorry, that's frustrating. Another way of doing this is paraphrasing, which is often really helpful when someone, sometimes we'll get callers who are talking for 10 minutes straight about kind of a whole period of their life story. And at the end of it, it can be helpful to just paraphrase just in a few sentences what they said to you. And it can be really helpful to organize their thoughts, especially when someone is kind of talking really fast or closer to a crisis moment, so that you're organizing their thoughts for them a little bit. And then there's also clarifications. So responding and asking for clarification. So if someone is saying something and you're still not really sure what exactly it is that they're asking for or what they're saying they experienced, clarifications can be really good. I think sometimes especially earlier on, I was worried that if I asked for a clarification, it would sound like I was saying I wasn't listening or I wasn't understanding them, but often people will really appreciate a clarification. So the next tool is validation. So validation is something that I'm sure a lot of people have heard of. Validation is letting people know that their feelings are real, are justified, are allowed. So effective validation often has two main components. So it identifies a specific emotion and it offers a justification for feeling that emotion. So it's not just saying, oh, yeah, it's okay. So this first example, saying, wow, that would be confusing, is a good example of identifying a specific emotion that it's confusing, and then also offering justification, saying, based off of what you told me, that would be confusing. So other things you can say, he really said that, I'd be angry too. So these are ways of identifying the specific emotion, but also offering justification and saying you really understand what their experience is like. Normalization is the next tool. And that's essentially, once we've identified how someone might be feeling, we really get a sense of what their emotions are, it's normalizing it, it's saying it's okay to feel that way. Something that I find can be really powerful, especially on a helpline call, especially for people who are earlier on in their journey with mental health, is to say, we get a lot of callers who are struggling with that lately, or that's something that we deal with a lot. Often that really just normalizes it. It puts it in the context of they're not burdening us. This isn't something that's too weird or unusual. And really framing it in the context of also that's something that NAMI, that we are designed to help with. So normalizing can be incredibly powerful. So the next tool set that we're gonna look at is within the pillar of psychoeducation. So really talking to people about mental health and really informing people on what the mental health system is all about and tools for coping with mental health. So the first one is pretty straightforward. It's sharing information. So this is just sharing information about mental illness or treatment that's relevant to what the caller is talking about. So sometimes this means that sharing what they're describing could be symptoms of a mental illness, or sharing that there are treatment options available and going a little bit more in depth about what treatment options are. And this really is based off of what you as a helpline responder feel comfortable, the information you have that you feel like you can share with them. So we have a number of helpline responders who know a little bit about different kinds of therapy, what the difference is between a Cvt therapist or a Dbt therapist. So those helpline responders, sometimes when they're talking to people who are looking to start treatment for the first time, those helpline responders will share information, not just about what therapists are available or how to find a therapist, but they'll share a little bit of information about what might be a good fit for that individual person based off of some questions that they might ask. Another tool within this is called coping skills enhancement, which is helping people develop the coping skills they already have or beginning them on the process to learning new ones. So I think often, especially earlier on the helpline, I felt the need that always I needed to find someone something new. I would need to find someone a new therapist or a new treatment option or anything like that, when really often I think asking them to develop the coping skills they already have, or really kind of reflecting back to them or showing them that they already have the strength to cope, can be even more powerful sometimes. So just asking questions like, has this ever happened to you in the past? And if they say yes, saying, what did you do then? And maybe the time it happened to them in the past, they did stuff and it wasn't really helpful, but then that's a really great opportunity to start talking to them and reflecting on, why didn't that work? Well, what could you have done better? And really asking them to start thinking and reflecting for themselves, what are their coping skills and what can they turn to? And the next tool is connecting people to their social supports. So similarly, I think sometimes I feel the urge to send people to a new treatment option, to find someone, a new therapist, to get someone into a support group. And those are all really, really important things. And also connecting people to the social supports they already have can be incredibly useful, can be really accessible for people also. So sometimes I'll talk to people and they'll say, oh, well, I've never talked to my spouse about my depression. You know, it's been really bad since COVID started. And I'll talk to them about why that isn't, why they don't talk to their spouse. And I'll try to ask them, who do they usually go to support? Have there been people in their past who have been really helpful for them with support? And how can we kind of build up those social ties a little bit better? Because if it's, for example, their spouse, they see their spouse every day. So potentially. So being able to talk to their spouse might be more helpful sometimes than going to a support group once a month. And then the last set of tools we're going to look at are referrals and resources. So these also are a little bit more straightforward. So this is, one tool is just referring to relevant outside organizations. So this is just collaboratively determining what organizations might be able to help the caller as a next step or two in coping and or resolving their issues. So this is, again, going to be really dependent on your individual helpline, what resources you have, what connections you have, what knowledge you have about different agencies and organizations and individuals in the area. And I'm sure this will be part of when we talk about Q&A and kind of how this presentation can be adapted to best reflect different people's, different groups' helplines. This will be a really important thing for people to determine. But always, like I said earlier, I try to think of this step as offering a menu of options and not saying, oh, you need to go to this therapist who I know of because this therapist is so great. This is often talking broadly about different options and starting to get more specific as you collaboratively work with them to figure out, oh, their son would never be interested in an inpatient program. Let's talk about outpatient programs instead, things like that. Next is referring to relevant NAMI programs. So this is pretty straightforward. This is similar process, collaboratively working to figure out what NAMI programs the caller would be most interested in, and then providing information and guidance on how to attend. And I think this is the last one. Lastly, is sharing a relevant book, website, or other information. So a referral doesn't just have to be sending people to an organization or a group. Sometimes we can refer people to a really good resource. So maybe there's something from a NAMI blog, maybe there's a book from a therapist or about therapy. Sometimes I'll refer, there's, the New York Times bestseller list has really good books about trauma or really good books about couples, being in a relationship from a couples counselor. And some of those can be really helpful for people to have something that they can do in between, support groups, in between, in the meantime, while they're trying to get other resources together, while they're trying to find a larger, more complete treatment plan. So lastly, this is that slide again that I have printed out. So these are the tools. These are the 3 pillars that we use. These are the tools that most often when you're on a helpline call, you're probably already using these tools. You're already relying on these things. And it's just, I think it's helpful to have shared language, to build out language for us to be able to notice what we're doing when we're doing it. I think with that, I'll pass it over to Christine.
Okay, thanks, Sam. And now we have the timeline of a helpline call, which we go through the greeting, presenting concern, the 3 pillars, action planning, and after the call work. Helpline calls are not always linear. Usually they follow a timeline similar to this. So for the greeting, I usually start out like, hello, this is NAMI New York State. I'm Chris. How can I help you? Depending on your helpline, it would, you know, if it's the affiliate phone call, you may not say it's a helpline. You just may answer as that affiliate. But I always say my first name to keep it more of a warm and welcoming greeting. And, you know, then always, how can I help you today? Or what can I do for you today? And many times, like at the state office, it may not be a helpline call. So I don't specifically address it as the NAMI New York State helpline when calling, answering. And presenting a concern. A presenting concern is the initial need that causes a person to reach out for us for help from finding a doctor, therapist, or another mental health provider. Many times this concern by the caller, you'll know right away what they're asking for, but a lot of times you're going to have to talk with them a little bit and try to figure it out and get a few more details from them, because they're not always really sure exactly what they're looking for themselves. So we always try to, you know, really listen and ask questions and really try to figure out what exactly it is they are in search of. So in the end, we can find the right resources and connections and, you know, help them dealing with all the issues that they may be going through. And again, we have the 3 pillars. The emotional support, we listen and validate our callers. The psychoeducation, we offer tips and strategies for learning and coping with their mental health issues. And then again, the referrals and resources. We provide appropriate resources and referrals for the callers to go on the next steps of their journey and, you know, get the help that they specifically need. And action planning. Determining the actions that it'll take for our caller to follow through on any resources we've given them. Restating before the end of the call what these actions are and any follow-up that you as a helpline responder will take. For example, many times I'll have a resource for them and, you know, or a website or listings of different groups that are going on. So I will generally ask for their email address and information. And then once I'm done with the call, I'll email all that information out to them so they clearly have it, other than them trying to write it all down as we're talking and, you know, getting it all correct. I'll just simply email it to them. A lot of times I may not have the answer right away. So again, I will get either their phone number or their email, research the information they're looking for, and then get back with them after the call. Yeah. If I'm not sure about this at the moment, but I want to get, whoops, go ahead, Sam. Okay, and then tips for ending a call. And this can get a little tricky too. You generally want to end a call by at least within 45 minutes. But sometimes that gets a little tricky to do because sometimes you just get on and, you know, you might resolve one problem and then that goes into another issue, or they just simply want to just have someone to talk to. But again, we don't always have the time. We're not a warm line. So we do need to limit the times of our calls. So usually what I do is, you know, if it starts running into that long amount of time, is let them know, now listen, let's go over specifically and make sure you do know that you've covered what they need for that time, and let them know you're going to have to end the call. Again, like I just said, you summarize the key points and make sure you've ended the call with what information they needed in the beginning of that call. And always end on what's next. So, you know, many times you can go over the steps that they need to take. Now, I've given you this information. Once we hang up, go ahead and call so-and-so and, you know, go on with your part of the resources that I gave you. If you feel that you've covered what the caller needs, but they keep circling, like I mentioned earlier, you can say something like, we've covered a lot in this conversation. Why don't you take time to think things over and call us back another time? Or, I'm sorry, but I have another caller on the line, but I'm so glad we connected today and you can always call me back. And again, many times that is something that I do have to do, because I will, you know, the caller will want to, I don't want to say drag out the call, but they want to just have someone to talk to. And I just simply have to say, you know, I have another call I have to take. Please feel free to call me back at another time, but I do need to end this call. And after work that comes after a call, if you're a larger affiliate, you may have to be in contact with your supervisor. Like I said, if you're giving the caller a lot of information, follow up with that email right after the call so you have everything. And you know, we tend to forget. So I immediately after the call will follow up with any emails and with resources or whatever I have promised them. Again, I research if I don't have the information, and I can't stress how important it is to know that it's okay to tell a caller you don't know. I don't have the answer for this. I will get back with you, because I'd rather say that than, you know, possibly giving them wrong information. It's okay to take the time and really research what they're looking for. And then again, each affiliate is going to be different with how they log their data for their calls. I know NAMI Metro uses a data service, I believe it's called Apricot. And us at the state office, we have an Excel spreadsheet that we created quite a few years ago, and it just, we fill in our own information, but then at the end it calculates everything, like how many calls I got for housing, what area the calls are coming from, different diagnoses, things like that. But each affiliate is going, you can create your own type of entry system. But it is important to log these calls in, in the sense that what you need to find the resources for after you've started taking several calls. You'll start seeing that pattern and knowing where you need to research for your area. And again, I believe, like, even when it comes to filing, applying for grants and things like that, to have that documentation of what you do for the community and, the help that you're giving people, having these logs will help in that sense too. And again, here is the comparison of how an info line, warm line, helpline, and the hotlines. And like Sam said earlier, we fall kind of in the middle. Some of my calls are as simple as I need to attend a support group in Buffalo. I would direct them directly to Buffalo. If I have their listing, I'll email them Buffalo's support group listings, and along with the contact information for that affiliate. When it comes to the warm line, yes, you will get people who just want to talk. And again, you try to be that listening ear, but the actual helpline is where you're finding the information, the resources, and, having that, that empathy and lived experience for the callers that you'll be getting. And again, self-disclosure is a personal choice. Everyone's experience is unique. What worked for you may not work for others. It may work for others, but you need to let them use their own judgment. If I have a caller and I've had a similar experience, I may say, well, when that happened for me, this really worked. But, you may want to look into it. I don't know if it'll work for you or not. But, I many times will give my own lived experience of what's worked for me. But I always stress that it may not work for you, but suggest that it did work for me. Anytime that you share information about yourself, you should have a clear idea of what it's accomplishing in your conversation. Like, is something I'm sharing for me or for the caller? Can I achieve the same outcome without sharing something about myself? And how can I maintain a boundary if the caller asks me more questions about this? And again, I do share, like, some of my experiences are what has worked for me, but I never go into great details. I just, I guess an example would be like when I'm really feeling stressed out. I don't go into the details of why I'm stressed out, but some of the breathing techniques that I have learned in the past can really help me come through that. But again, I don't share my stressor details or anything like that. Just what has helped me get through my stressors. And this is what we don't do on the helpline. We never offer advice. Reach out to a resource or a family on a caller's behalf. I know many times they will, like, persons will ask me to like contact the police or an attorney or a court for their loved ones or for themselves. That is not something we can do. Share personal contact information. That can, that can get dangerous because we don't always really know who we have on the other end of the phone. And not dangerous, but, it can open yourself up to never having your own personal space anymore either. You never diagnose people. And crisis intervention or call the police for another hotline. We don't do any of those things. Obstacles to a good helpline response: negative judgment, jumping to conclusions, assumptions, being closed-minded, short attention span, wishful hearing, somatics, talking, listening, lack of humility, and fear. So again, what do you do if you don't know what to do? Like I said earlier, it's okay to tell them that you don't have the answer for their questions. And this, again, just get their information, reassure them that you're going to look into it and find the correct information for them. And, sometimes this can take a while, but just, keep reassuring them that you will get back to them, and do get back to them, even if you're not sure if you found the correct information, even at that time. You may have to reach out to others in the state office, in the affiliate, national possibly, to get some of these resources. And please remember, it's always okay to ask for help. I mean, I know I do. I ask others, if I don't have the direct answer, I'll ask several other people in the office if they're familiar with whatever the situation may be, and, reaching out to other affiliates even. So it's okay to get help. And then, of course, self-care and self-management is very important. This is, Sam, I'm not real familiar with this wheel. I know it's something that you use with your folks. I know, like with me, it's generally just me. But the importance of self-care, I can't stress enough. Because many times you're going to get on a call, and at the end of that call, it can be really overwhelming for you to have to take in all the information you just were presented with. And many of them can be upsetting. You don't know when you hang up what has happened to actually happening with the person. So many times, I just have to take those few minutes to either get up and walk around, or like I said, I do a lot of breathing techniques that just gives me that space to center myself again, because it will happen. You will get on calls that are totally overwhelming and upsetting, but then you'll get those great calls too. And it's like, you just want to shout for joy because the person on the other end was so thankful for you that, you give yourself that a little support on the pat on the back as well. But Sam, I don't know if you wanted to get into this chart a little more, or
Sure.
if it's
So just very briefly, I'll say, so this wheel is called a feelings wheel. So essentially, at the center are a little bit more basic emotions. emotions that usually are pretty easy for people to identify within themselves or others. And then as you kind of follow the wheel out, the spokes out, it's a little bit more nuanced emotions. So, in a given moment, you might be able to say that, oh, I know I'm feeling happy right now, but, as you follow it out, you might say, well, I'm not just happy, I'm specifically proud, or I'm not specifically just proud, I'm feeling successful. And so one of the things we talk with our helpline responders about is being able to take your own emotional pulse, being able to recognize the feelings that you are having while they're happening so that you don't get too overwhelmed, because it's much easier to answer when you're able to know how you're feeling and feel centered and like comfortable with what you're experiencing. And then we also talk about, usually I'll lead people in an exercise before they become a helpline responder, and taking a look at this wheel and thinking, what emotions do you anticipate feeling while you're on the helpline? And usually that can be really helpful, either before a shift or just before you become a helpline responder, to start to think through what are some things you might feel and how might you react if you start to feel those ways.
Thank you, Sam. And again, I believe that is the end of our slideshow. I know, Sam, and this would be a question for you. Somebody just asked if you can share the site where you found that chart.
Sure, yeah. So if you Google feelings wheel, there's a lot of different versions of them.
Oh,
but
okay.
I believe the presentation was already sent out in an email. So feel free to, it should be in there. I'm also going to put my email address in the chat right now in case anyone has questions about that or anything else. Feel free to follow up with me. I think now might be a good time for questions. Any questions that came up, any discussion?
That would be great. And let me say, Christine and Sam, thank you so much for putting this together. I see Sherry did write something in the chat about some of her challenge. She says the most challenging calls we get with divergent ideal goals is the family member so fed up, they want to know who will help them sue someone, usually a provider, authority, etc. They are momentarily unable to center and focus on their loved one's care needs until they can tell their story and vent and be received with empathy. So, yeah, I think we've all probably encountered that.
Yeah, I tend to get a lot of those calls where, unfortunately, many times the family member doesn't want to receive the help either, and the family is just like at their wits' end. The system has kind of failed them at that point, and but again, it's just I think being that listening ear and empathizing with them, and many times, like you said, they're so caught up in their own anger right at that time that it's kind of hard to I don't want to say get through to them, but in a sense, but that is where, I'll say something like, as unfair as it is, this is where we need to help ourselves, and I would guide them into getting into the support groups, or recommend family to family for them to better help themselves at this point, because until our loved ones are ready, they're not going to get the help for themselves. Sam, do you have?
Yeah, I would just completely agree with everything Christine said. I think also sometimes anger comes up because it's something that you can do. If you say, oh, I want to sue someone, I want to figure out how I can, make justice, get some sort of justice out of this. It provides something else that you can do when there aren't a lot of options, when often something that happens for loved ones of people with mental illness is they feel so out of control. They feel like they have no ability to do anything, but taking legal action is something very concrete that people can do with all of the anger.
So yeah, does anyone have any questions or want to comment on, taking calls to their affiliate, anything?
Wendy, yes, may I ask, it's Roy,
Yep.
May I ask Sam a question?
Of course.
Thank you. Sam, if they have made the visit to the hospital emergency room and they're released, and it's multiple visits, same hospitals, different hospitals, and they diagnose a condition, and then they release you, and there's a time span from that release time to counseling or therapy. What do you do within that space of time with that person? What rights do you have with the hospital to strong word, but to demand better service?
Yeah, it's a really, really great question. It's a really difficult situation that I feel like we encounter on the helpline all the time. Christine, I'd be curious to hear your perspectives too. I would say ultimately it's going to be so case dependent. In New York City, thankfully, there's a number of partial hospitalization programs. There's a lot of outpatient options that we try to refer people to. Because in New York City, there's just a variety of them, we're able to usually say if one hospital isn't listening to you, here's the information for a few other ones that might be able to help. But often there's not enough resources. Often we just hit the wall of, there's not great options. And so often it comes down to making sure there's some sort of other care plan in place, making sure that, there's other, outpatient therapy, there's social supports checking in with the person. And there are a lot more things like that. But unfortunately, I think there's no easy answer.
I get calls for NAMI Putnam County, and those are the cases. My son's in the hospital right now. This is the 4th visit. They're releasing him tomorrow. What do I do? So I try to get in touch with housing or an additional therapist, things like that. But like you said, you run into a stone wall.
Yeah, I agree. It can be very frustrating in those situations. And again, I agree with Sam. You try to give them the resources for anything that could be like on an outpatient. I know, some areas have we have a couple, it's kind of like a stabilization center, but like living rooms where folks can go to stay for a little bit. Possibly that could be an alternative until they can get to their permanent place. But again, like Sam said, and Roy, I'm sure we don't have the resources available always. And, when you get those calls, those are ones that are very frustrating when you hang up because there isn't always anything we can do to help them.
Right. I do follow-up calls on referrals that I send out. Is that okay? Just to say, I gave you this number, this organization, did you get through? Is that okay or not?
I don't generally follow up.
Okay.
Many times if I give a referral or a number or another agency and the person I gave it to cannot get through to them, they will call me back. But I generally, honestly, I don't make it a rule to follow up on my calls unless it's something that I promised them that I would get back with them with.
Well,
Sam,
it was exactly that. Somebody called me back and said, Roy, the numbers you gave me, they haven't even returned my call yet. So I'll get back to them after I make the call to the numbers I referred them to and see what, is going on.
Yeah.
okay.
Yeah, I would say,
Is that okay?
it's going to be it's really going to be dependent on the individual affiliate. I see nothing wrong with following up. At NAMI in New York City, we have too high of a call volume to follow up with each individual person. So if you have the ability to, I think that's an amazing thing to do. We send out a survey at the end of the month to all people who called into us, who gave us their contact information, and we ask, is there any other way we can help? We also, this wasn't in the presentation, but I always end every call with, if there's anything else that you need, please call back. Or if any of the referrals I gave you weren't able to respond, please call back. And often people just so appreciate that personal touch of someone actually caring for them.
They do, yes.
Yeah, I agree. I do that too, Sam. And, even in my emails, after I've sent them all the information, I always say, please don't hesitate if you have any further questions to, contact me again, and, we're always here. So. Yeah.
Same page. Okay, thank you.
Any other questions?
I have a quick question that's
Yep,
kind of
Katie.
along those same lines. So I find right now we're getting a lot of calls from people who are saying things like they cannot find a therapist. No one's calling them back. No one's taking new patients. And it's even more, I mean, that's always been a problem. And now it's really escalated. And I never recommend therapists, but I certainly do refer them to people who I think would be a good fit. And I don't want to give them anyone who's not taking patients. So I find I'm spending a lot of time now kind of calling therapists to try to get in touch. And are you taking new patients before I give out their name? Because I don't want to further frustrate people. And I'm wondering if anyone has has anyone developed any unique good tips for like keeping track of that information with local therapists? I'm just finding it very cumbersome to kind of get that information updated frequently.
It's a great question. We've tried a few different systems at NAMI New York City. So one thing is we do use the Psychology Today website. They have a platform where they have different numbers for therapists. One thing we do with our callers is we'll often give them the name of 4 or 5 different therapists and say, it might take a while. You might have to call all of these 5 numbers, and then only 2 will respond, and one of them will say, oh, but I don't have any openings right now.
Right.
And just we really try to prep people as much in advance that might happen. The other thing we started doing, which has been a pretty big game changer, is we refer much more to clinics, to like graduate school clinics. So if there are graduate schools of social work or psychology in your area at all, they so often have huge ability to take cases in. And what I like about that is then I don't need to know exactly the best fit of therapist for the caller who's calling into me. I can say to that caller, call the intake specialist at the graduate clinic, and that person will be able to really talk you through and match you up one-to-one with a really good therapist.
Do you think those clinics, are they seeing people through telehealth now? And do you think we would be, as a Rockland resident, be able to use them? Because we don't have a graduate school here, but could I tap into that?
Possibly, it might be worth calling. I know there's a bunch in the Bronx that might be close enough that certainly telehealth would be easy, but if not, then maybe some people would be able to drive out there.
Okay, thank you.
Yeah, and I agree, like Sam said, but I also, that is when I suggest that maybe they start attending support groups like the Connection or the Family Support Group to get with those other folks that have been successful in finding someone that they really like, and they can maybe get 4 or 5 different therapists' names at that group at the time they go to, get those extra leads too.
Mm-hmm.
Joanne, you had a question?
I was just going to say what Christine said. That's a great time to tell them lived experience. Everything I've learned, I learned from support groups. So
yes,
go to the support group in the area you're looking. And then our local Mental Health America of Dutchess County, they do have, if it's private insurance, somebody there who does have a list. So I refer them to them. But again, it depends if it's private or public. And I have a short list as well, but I direct them, it's exactly at Christine, to the support groups.
Thanks, Joanne. Sherry, you had a comment, question?
Joanne just actually covered part of what I was going to say. Our mental health association advocates, now mental health advocates office, did a periodic survey of area private therapists who were accepting new patients, and then whether they only took private pay or they would take Medicaid, which was really important for so many of our people. There's no good answer for how long it takes, and we at least try to help people really understand that, and you muddle through as best you can and come to support group. So if your affiliate is small like we are, and your MHA has way more staff than you do, maybe they could work on doing that kind of a survey or list if you have a good relationship with them and they're open to it. And I do think telehealth is going to be a game changer, especially now in New York State because of the governor being so hepped up about it. But so those are all things that we have to look at and just do the best we can and assure people that even if it's a long wait, which it certainly will be, that they're not alone and come to support group. So.
Yeah, and Wendy, I saw somewhere that someone said that it sounds like we recommend therapists. I do not. I recommend like through the county, checking with their insurance. But the main thing, like I covered that I do, is suggest the support groups, because the folks at the support groups can recommend. They can say this person worked great. But no, I don't specifically recommend therapists, doctors, anything like that other than the county services or state.
Yeah, and sorry if it seemed a little bit unclear from what I was saying. We'll provide that kind of those 5 options as a listing and not say, here are 5 therapists who you should definitely see. We'll say,
Yes.
as long as you're looking for therapists, here's, and we usually base it off of their location, the things that they do ask for, rather than us, you know, kind of making that strong recommendation to them.
So any last question or comment before we kind of finish up here? Joanne, your hand's still raised, but you're good, right?
Oh, it's Judy.
Yep, Judy, go ahead.
Again, sort of being, you know, on Zero Suicide Committee, what would be a resource, or how would you respond? Because I know I've been in that situation, getting phone calls, and our families, of course, have. What would you say is the best resource other than calling 911 or getting them to the hospital ED? I mean, I know that's not.
You mean for a crisis or an attempted suicide? Is that what you're referring to?
Yeah, or someone who's feeling highly suicidal. Families who know their person is suicidal, but in the hospital they're looking good. And if the person is coming home to their house, in one situation I had, I told the family they have to go up and talk to the staff to say that, you know, that she's not ready to come back to their house. They can't take her back because of dangerousness. And they did that, and the hospital did respond, but otherwise she would have been discharged. But that was a phone call that came through. So I just wondered if there's any more comments about the safety issues that sometimes can come up. Any recommendations?
Those are tough ones, and they'd all be like individual cases. I know I have rarely gotten any calls where the person is suicidal at the time. They may have been before or previously to calling me. But if I have someone who is, you know, on the verge of crisis, I'm going to keep on the line with them, you know, talk them down and convince them, or hopefully convince them to get in and get the treatment that they need, or, you know, call that crisis number if it's a family member. Most of every county has a crisis number. And, you know, it's a tough call, Judy. It's, again, individually based on how the situation is playing out. Sam, you might have more.
Yeah, I would definitely say exactly like what Christine's saying. It's going to be so context dependent. One thing I'll say is we could do a whole nother presentation just on responding to suicidal callers.
Right.
We often will strongly recommend, and this is one of the times where, you know, we don't offer advice, but we'll really push for people to call the National Suicide Prevention Lifeline if they're comfortable. So we'll often say, you know, we would really encourage you to call right afterwards. We'll say something along the lines of, we care about you and want to make sure that you get the best treatment possible right now. We're not a suicide hotline, So we actually aren't prepared for calls to talk about suicide. We'd love to talk to you about anything else that's relevant or that's coming up, because I think sometimes what happens often is people will be experiencing suicidality or suicidal thoughts at the same time that they're dealing with a housing crisis or dealing with trying to get into a support group. And so it's important to still make sure that they're getting whatever other needs they have that aren't suicide related, make sure that they have those needs met. So we really encourage our responders to still stay on the phone and respond to all the other needs. And then if there's something that might require calling the suicide hotline, we can either transfer them with their permission or just encourage them to call. But we're working on developing there are different scales to understand just quite how far along in the process someone is to contemplating suicide or to attempting suicide. So we're also starting to develop a training for our helpline responders around that. And I know the American Foundation for Suicide Prevention offers really good ones on that.
Yes.
Yeah, I think that would be good for us to just be aware of, and the idea of transferring, to the suicide hotline is also a good recommendation. I know I've had families call me, and their ill person is, talking about wanting to die, and they're wondering, who to call or what can they do or say. So, at that time we try to get them to the emergency room, but.
Judy? Right. And I if it's a family member and they're really concerned, I say if you're really in doubt, make that call, to crisis or.
It's Pat. I just wanted to jump in here. And most of the time, in my experience when I was in the affiliate there, it's going to be the calls from the family members, not the person themselves. So what you were saying, Judy, I thought was right on. I mean, to really, encourage and empower the family to do what they did. Going to the hospital, contacting them, and just simply tell. It doesn't mean always, of course, sadly, that the hospital will respond, but you're putting that out there, and so that's, and then the idea that if they are released back home and there's still danger or threatening suicide, that they don't give up. You go through the process again, calling, getting them into emergency, calling the crisis team. Yeah. So because most of the calls.
Thanks, Pat.
Yeah. Oh, sure.
Sherry, you get the last word.
When Rhoda was talking about the family having contacted the hospital and letting them know, again, just sometimes it's navigating the HIPAA stuff, and we spend a lot of time assuring families that you're going to weigh in the balance. How mad is your person going to be that you spoke to somebody if they have not signed a HIPAA waiver? And sometimes you have to do that anyway. And the other big area where we devote a lot of time is when the family is like, they need housing, and there's a crisis coming, or they've just been hospitalized. And we make it a really strong point here to say to them, you need to start saying, as soon as people show up and that person is headed to the hospital, not discharge planning, that they cannot come home to you, because it triggers a whole lot of things that move them up the housing urgency food chain. Even though there's not a lot of good answers, at least they're going to be closer to the top of the pile. And then assuring them that they need to be prepared to back that up, even if it's a discharge to city mission for a few days, because that's the reality where we are. So we try to give people practical strategies. There's the polite whatever on the surface, here's the chart and how it goes. But we also try within reason to give them and this is how it really works for NAMI families version, including using our name sometimes, not always, but sometimes.
So, well, this was really great. Again, Christine and Sam, thank you so much for putting this together. And thank you for joining us and sharing a lot of information
thank
both
you.
In the chat and, with the group. So again, I did record this, so we'll be able to make this available for you certainly again and others. And I know a couple people asked about the slides. I did send out the slides yesterday with the reminder, but if anyone didn't get them and you want them, we can send them out. And we'll probably link it to when we do our affiliate call next week for anyone who wants to join us. So yeah, if you come up with anything else and you have questions, I know Sam put his email in the chat, but I can always pass on if you email me, I can always pass on the questions to either Sam or Christine as well. So thank you all so very much.
Thank you.
Have a
Thank
great
you.
weekend.
Wendy and
Thank
Sam,
you.
Christine, and everybody. Thank you.
everyone.
Thank you.
Yeah, this was great.
All right, thanks a lot.
Have a good day. Stay safe.
You too.